I was just also on a children's hospital Zoom. It was called um, a large division-wide town hall meeting, and they shared that DPS just announced within the last hour or two that in-person learning will not occur in DPS schools until October 16th at the earliest. And that's a surprise because we previously were told to the first week in September. So hopefully we're going to get more information on logistics on why that's the case. This has been a big topic for many of us, particularly in pediatrics. But all of us, is our lives going to be going back to some semblance of normal in the fall? And can our kids go to school, and should they go to school? There's still a lot of fear, less fear in some, more fear in others. And what's the data to guide us? So, big questions that I sat back and asked myself an example for my daughter or my pediatric patients. What are the risks of my child getting an infection by going back to school? What data can drive us and give us some information on that? If our children get the infection, what is the risk that to my child of a severe illness compared to a minor cold or flu-like symptoms in other times? But also very important, and I think this is the biggest concern for epidemiologists, the state, and everything else, is what's the risk of severe illness for the known higher risk people, such as parents, grandparents, and teachers. But balancing that with what is the loss to my child and our children in the community if they don't return to in-person classes. So for some families and households, childcare is an issue. And then if the kids can't go back to school, one of the parents may not be able to go back to work, and that could severely impact that household and the family. Mental health concerns is a big issue. Colorado, surprisingly to us, has one of the higher incidents of teen suicides. And so for many adolescents, the social networking in school is important, but also the mental health and psychological support services that we have in our schools is also very important. For some of our families, this is the only chance they're going to get a good meal for the day, 1 or 2 meals, and that's a very important piece. Most of Denver public schools continued the food plan at some schools, even though there was no in-person school during the lockdown. What about falling behind? What about our kids who either struggle in school or have aspirations to be going to the top universities in the country? How is this going to set them back? And that's a real concern for many parents. And what about families that just can't do remote learning? This is a bigger issue for a lot of our younger kids and the parents trying to, for many children, do remote learning for younger children, but also if they don't have resources for internet and Wi-Fi access at home. So there's a lot of issues that are competing, and this should not be political. So as of July, both the American Board of Pediatrics has said that in-person school learning should return because of the balance of the illness to the kids versus those other aspects that are so important for our children's growth. The CDC has just released guidelines of how in-person schooling can return, and these are guidelines for school districts and schools, and takes into account what is the prevalence of infection and the spread in those communities. So what I want to do is talk about what's our local prevalence, what's the mortality, what do we know by COVID now, a lot more information than we did, let's say, in April and May. We'll take a deeper dive into the Colorado numbers. Again, talk about some risk factors for SARS. I'm not going to talk about treatment unless you want to. Talk a little bit about a vaccine, and can we safely reopen our society, churches, and the rest of our lives. So as of today, sorry I didn't update this date. My last talk that I gave on this to our church was in June, but as of today, July 29th, there's 45,000 confirmed cases in Colorado, with 1,800 deaths among COVID infected patients, but 1,200 believed to be caused by COVID. In Denver County, there's 9,000 cases reported, which is 20% of our state infections, but represents about 32% of the state's deaths. Adams County, 5,700, 12%, and about 13% of the deaths. Arapahoe County, 6,000 cases, 14% of the cases, and 28% of the deaths. I'm sorry, I didn't include other counties such as Douglas and Jeffco, as well as Boulder, which may be represented on this call. Again, some information that I think is helpful is one of the society, the IHME predictions for Colorado, which looks at the total number of ICU bed capacity if we get a severe second surge, and our hospital is going to be overwhelmed, like they're talking about in the Texas border towns right now and what happened in New York City. The data that I get for these numbers up top just come from the Colorado Department of Public Health case data forms. And what I recommend, if you're interested in what the CDC has to say, here's the CDC website on school reopening. So what about our case numbers in Colorado by age? As has been discussed before, the highest risk of death is among people 50 years of age and older. This has an impact on families, parents, uncles, grandparents that may be in the house of kids going back to school. What is the risk factor, or the teachers themselves have a higher risk of severe illness. We're very fortunate though, but when we talk about our kids themselves, we have not had one identifiable death in a child less than 9 in Colorado. And we've only had a few deaths in adolescents aged 10 to 17. So if you look at it, approximately 25%, almost 25% of Colorado's population is 19 or less, but that represents only about 8% of the total, 9% of the total infections. And of those, most of those infections are mild. So this is one disease we can be very happy for our kids that they don't seem to be getting it as much. And if they do, it's so mild, it may go undetected as opposed to older adults. So this is one thing. And one thing we've learned, I don't have any slides because we don't have hard data on this, but this is a 2 hearts. This is a congenital heart group. To my knowledge, we have not had any of our congenital heart kids through Children's Hospital Colorado die from COVID. And my understanding is we have only had a handful, and it may only be up to 3 of our kids at most who have been hospitalized at all for close observation and were able to go home. So congenital heart disease, at least in children, does not seem to be a risk factor that we know of, but it could be that our parents are doing such a good job of not letting our kids be exposed so that the infection rate is low and we don't truly know what the risk is still. When we look at how the disease is spreading in Colorado, you got to be cautious at looking at these numbers, as many people are saying, yes, we have much more testing than we used to have earlier in the pandemic. So here we can see now our total numbers per day of infections are almost the same as those we identified at the peak in the end of April. But we have so much more testing than we had back then. If you look at the number of tests we were able to do at April, it was anywhere between 2,000 to 4,000. And now we're testing anywhere from about 13,000 to 17,000 patients per day. So looking at this graph, which is a little bit more complex, this is the number of tests per day that are run in Colorado. And this is the number of percent of tests that are run that are positive. Public health officials say that number should be below 5% if we are able to keep it under control in our region. So early on, obviously, it wasn't being controlled and our hospitals were being overwhelmed. Now, even though our numbers look worrisome in the total number, the percent positive tests are just below 5%. So that's a debate. In the last town hall meeting from Children's I was just on in the last hour, that's a discussion amongst the experts. Is this still an accurate number for us to follow? One of the things we look at is of the people infected, and this is from the School of Public Health, they do what's called the R0, or the infectivity of each person who's infected. So early on, they estimated that each individual who was infected was on average affecting anywhere between 4 to 5 people. When we got control of this, just as we started opening up, each infected person was infecting less than 1 person. So it was not spreading in the community, and it was dropping. However, that number has gone up and it's getting close to 2. So every person infected now is starting to infect about 2. So there's a worrisome trajectory as we're going into the phase when we're talking about opening up our community more, particularly our schools. And one of the things the state has to really worry about is our capacity to treat all those that do require hospitalization. You can see early on, the rate of increase in hospitalizations was very steep on this curve, and then it flattened, and now that curve is starting to go up, but not nearly as the pace that it did. Despite the number of case counts going up, the number of deaths are very low, which is fortunate. And why is that? Well, yes, we do have treatments, and they do seem to be effective on many, number one. Number two, a higher risk population, those older than 60, still are, for the most part, restricting their contact with other people so they're not getting infected. And for the most part, we've got our nursing home populations controlled, although we still worry about the prisons a little bit. So from the School of Public Health, looking at the incidence cases by age of infectivity. So early on, it was a combination of those older than 40, all adults really, and kids 0 to 19 remain fairly small. Even before we closed down the schools in May, relatively, suggesting kids may not get infected as much as adults. And there's some biological plausibility to this theory that kids just may not get infected as much as adults, and they may not be carriers. Certainly the younger kids, probably less infectious and less likely to get severely infected. But as we've reopened, the number of young adults cases is spiking. And this is partly why when you look at the older population, very few are getting infected. And most of these are 20 to 64. So the death rate and the number of infections has remained relatively low. But when you look at the number of hospitalizations, so looking at not just who's getting infected, but hospitalizations, the number of kids that have required hospitalization has been extraordinarily low. So despite those having many kids with cancers, congenital heart disease, chronic lung disease, asthma. Very few of them are getting very severe illnesses. And I know of only, I think there's probably more than one case, but I think it's at most a handful of cases that have died at Children's Hospital. And I personally only know of one that was publicized in the media. So just some facts, not much of this has really changed. This is from slides early on. We know this virus remains stable in aerosolized form for about 3 hours, perhaps even longer. Remains stable on surfaces for a long time, hence the need to clean surfaces after people have congregated there. The median incubation time from exposure to symptoms is about 4 to 5 days. And it's still been debated even within the WHO on are patients without symptoms infectious. Most of us believe they are, but certainly when you have more symptoms, you're going to be coughing more and creating more aerosolized material, and the infectivity is certainly higher. The vast majority will have developed symptoms by 12 days, and hence the 14-day quarantine time. Most will develop a fever at some point, but for older adults, the fever can be a later sign where they have significant lung involvement and require oxygen supplementation and hence admission to the hospital. So fever could be a later sign of the illness. Dry cough could be productive. Rhinorrhea is not as big of an issue in this illness, and GI symptoms can occur. And you also have the nausea where you lose smell. About 81% early on is mild symptoms. This is rising to closer to 90% now as more young folks are getting infected and we're identifying more illnesses. 5% developed critical disease requiring oxygen intubation. And of those, it used to be those that close to a 50% mortality in those that were admitted to the ICU. That's dropped to about 20 to 30% as we have much better testing and treatments that we can start early. And we're aware of some of the problems such as blood clotting that can occur, and we treated it earlier. Case fatalities, very uncommon without comorbidities. A little bit higher, but these are adult diseases. This 10% is not congenital heart disease. So pillars for preventing infection. To date, both at Children's and University, I just got off as I said, the town hall at Children's, and about 100 staff members through Children's have known to become infected. It's believed all of them were in the community, and none of them from taking care of any of our kids with COVID or from adult colleagues who are infected that were at work. Pillars to reduce infection are face masks. This isn't a political thing. It works. It doesn't work by itself. It's not the end all be all, but it works. And there's little reason not to use a face mask in public. Social distancing, it helps. It's not the end all be all either. Frequent hand washing, so we're not spreading the virus to other surfaces or touching the virus on a surface and then touching our faces. Meticulous cleaning of surfaces. Quarantine for those that were exposed without proper personal protective equipment. So if you were around a person for 10 minutes or more and neither of you were wearing a mask, then that puts you at higher risk, and perhaps we should be quarantining those. That's gone up and down based on our experts on how long and what needs to be done. Contact tracing. The United States has done a very, very poor job at this, and Colorado has been doing a fairly poor job as well. But one of the things I just learned on the town hall an hour ago is that a lot of the reagents, our testing in Colorado is ranked probably about 43 out of 50 in the country. And part of that is because a lot of the reagents for testing is being deployed to many of the other states, such as Florida, Arizona, Texas, and California. So our ability to have adequate testing is still limited in Colorado. Well, vaccines. I mean, there is some hope, and this is good news. Many of you may have heard, I know of at least 2 vaccine trials that are going to be starting in Colorado. One is by a company called Moderna, which is based in Cambridge, Massachusetts. And this is with the first of its kind platform where it's called an RNA vaccine. What does this mean? Well, they're not using live virus. They're taking RNA itself from COVID virus and enclosing it in a lipid molecule and injecting it into the muscle. The muscle takes that and creates from the RNA just the spike protein that we see on the pictures on the news, so that your body recognizes that as foreign material and starts to create antibodies. And the initial phase 1 and phase 2 trials suggested at certain doses with 2 doses over a month period that there's good antibody production. We don't know that that correlates with protecting against the infection. So the phase 3 study, of which there's going to be about 33,000 patients with this vaccine in the United States, started this week. And we expect about 1,000 people through University of Colorado Hospital to be enrolled in this. This will tell us, of those that are infected or that are vaccinated, how many of them get infected, and if they're infected, how many get severe disease compared to those that weren't infected. We're not going to have results of this until December, January. So we're not going to have large numbers of this vaccine until likely 2021. Northern Colorado through UC Health is going to be involved in a different vaccine trial. I think it's the Pfizer one that has been discussed, that our government has invested, I think it's $2 trillion in Pfizer to have access to that vaccine once they can be made in bulk if it's effective. So that phase 3 trial is going in sometime soon. But as I said, don't expect the FDA to get approval for a mass vaccination until at the very earliest, the end of this year, more likely end of winter, early spring in 2021. So our school year this year, we're not likely to have vaccines. Hopefully we will next year. School readiness. I think it's important to keep in mind the school readiness is gonna really vary based on resources for each school in each school district. It's been very clearly big in the media that both race and socioeconomic factors lead to more severe illness, higher concentration of infectivity, but also more severe illness. And this is also within our schools. If you look in the greater Denver area, where very wealthy school districts such as Cherry Creek has more resources to approach a hybrid approach effectively and well than such as Denver Public Schools. Jeffco may be somewhere in between, Boulder also different. So we have different resources. And those of us that understand the primary and secondary education funding in Colorado, Colorado is one of the worst in the country in resources that we can put into primary and secondary education. And now with the Colorado budget being decimated by this, there's even less resources to give to the schools to help prepare. So each school district has to do this per their resources, the risk of their staff, not only the teachers, but the other staff, but also the parents, and how much is this virus spreading amongst the different counties. When I was looking at the data today, Jeffco is relatively spared compared to Denver, Arapahoe, and Adams County, and certainly Logan's County Logan County, sorry, in the Northeast, where the rate of spread is much, much higher. So that would impact the ability of those different school districts. We shouldn't have Metro Denver all could do the same thing because the spread is different amongst different communities. My thoughts. Based on the low infection risk to the children, particularly primary age 4 to 10, I think schools should reopen in some fashion this fall for in-person activity. Those schools with more resources who can increase social distancing, great. Those that may be able to do a hybrid to increase social distancing where some kids come in during some days and not, so there's less exposure, great. Those that can create what we call pods, where many primary schools education follow, where you have one teacher with one class the entire day to minimize the spread of infection amongst the entire school. But it's really important for parents to become very educated about the preparations of their child's school, of the safety and tracking within that school. As I mentioned, we have no evidence to date that most congenital heart disease patients, that congenital heart disease places any increased risk of infection or severe infection, although we still worry about some of our patient populations. The biggest risk with our school reopenings is really on the adults that are surrounding our children, the teachers, the staff, the families. Those older than 20, and particularly those that have high risk factors such as obesity, diabetes, high blood pressure or hypertension, and chronic lung disease. So I really wanted to open this for questions. So that's all I have on formal talks, and I'll stop sharing.
Okay, I have a question.
Sure.
Out of all the deaths, has anyone figured out if it's just from the COVID or is it from a chronic illness that was exacerbated by COVID?
Yeah. So if you look at the state numbers, they are now presented deaths with COVID or death by COVID. And those that are with COVID are those that believe to have died from other things, like they had severe heart failure before they had COVID, and COVID may have tipped them over the edge, but it was really the heart failure that they were going to die from that was the coroner claims as the cause of death.
Okay, that's what I wondered when we were looking at it. I was trying to figure out what that meant.
Yeah.
Okay. Anybody else have questions?
Hey Joe, it's David Rush. I've got a quick question. You mentioned about the vaccine trial that was going through university. Is that being targeted mostly at like frontline workers, or who's in line to get that?
Yeah, I still haven't heard definitively. The infectious disease doctor, who's the local primary investigator, are looking through and identifying high-risk healthcare workers, inviting them to be subjects, but also high-risk patients. And I don't know how they are stratifying the high-risk patients who are being invited into the trial, whether it's just based on obesity, diabetes, or what. And then they are inviting people into the trial and going on tiers.
Okay, thanks.
Anyone else?
I've got a couple of questions. Hopefully they're really quick. So in the news lately, we've heard a lot of things, but one of the things I've read a couple of times has been people who do get COVID, a large percentage, like I think it's over 73%, end up having heart issues going forward. Do you have any comments on that?
So yeah, no, it's not 70%. Um, it could be 70% of those with severe COVID that were in the ICU. But it's a small minority that are getting heart problems. Now, what we're still trying to find out, and some of my colleagues in adult cardiology have gotten grants to look at this a little more carefully. We don't know if COVID can cause a primary cardiomyopathy. So one of the leading causes of need for transplant, cardiac transplant in the pediatric population is cardiomyopathy. Whether it's viral cardiomyopathy, there's certain viruses that we know can cause direct infection and worsening function of the heart, such as Coxsackie virus, adenovirus, those that have been shown to really affect. We don't know what that risk is with COVID. We see frequently in patients, adult patients who come in, and kids as well, with severe illness in sepsis, either from bacterial infection or influenza, and develop what they call RDS, respiratory distress syndrome, on the ventilator, that the heart function fails as well. But this isn't necessarily from severe viral infection of the heart. It's this diffuse inflammation. Analogous, what we're seeing with this unique pediatric illness called MISC, so multiple inflammatory systemic disorder in kids. And so because the immune system goes haywire, it attacks the heart. So it's not the direct virus infecting and weakening the heart, it's the immune system. When it's the immune system, not always, but usually, those hearts get better. And there's a disorder we don't see in kids very often, we see in adults. Some people call it sad heart syndrome, or stress-induced cardiomyopathy, or another word is called, the first term was Takotsubo cardiomyopathy, which is based on the octopus traps, which because it's on echo, it causes a certain change in how the heart looks, like it was in one of these octopus traps.
Okay.
And most of those people's hearts get better.
All right.
So we're still learning about that. For this MISC, we have protocols at Children's that we in cardiology get involved. It's mostly the cardiomyopathy heart failure team that get involved with those patients, as well as infectious disease, rheumatology, and we're following those, and they go into registries and we look at how severe that is. I don't believe in Denver we have seen a single cardiac patient with this MISC. So heart disease is not a risk factor for it. It's likely a genetic component of the immune system.
One quick last question. We've got Ethan is our heart transplant child. You've met him before, you know his background a little bit. But we've got an older son in Seattle who would like to come home from college for like a week. Does that pose a higher risk for somebody who's been a year plus now, a year and 4 or 5 months post-transplant?
Yeah.
I mean, is that something that we probably shouldn't even consider, or?
Well, that's something I would talk to your transplant coordinators and the transplant doctors. Not being a transplant cardiologist, I haven't been following the literature on the effects of COVID on those that are immunosuppressed. In one arm, you think the immunosuppression actually may help because it prevents the severe immune syndrome that occurs, but at the same time, they may not be able to clear the virus and it sticks around and causes severe illness.
Right.
So I would talk to your team. They're better versed than I would be.
I just wanted to throw it out. So appreciate it.
Anyone else have questions?
I have one other question, and I know that we kind of talked about this before you, but on a private call, but like testing, access to testing for CHD patients, you know, old or young, like, is there easier access, like, or how would you recommend that, you know, if we ever suspect, you know, that there's something, should we be contacting you guys or what?
So they're trying to make it as easy as possible to control the pandemic and spread so that people, particularly people without resources, don't have to go to don't have to have a doctor, and they can just sign up and go to one of the testing centers. For those that are patients at either university or children's hospital, for the adult patients, you don't even have to let your doctor know. You can use the app, the My Health Connection, and schedule a test for yourself and just go. The one advantage of letting us know and have us order it is the results will come to us. And so we'll know it and we can discuss with you. But that is a relatively easy approach. At Children's, I don't know, I think we as the providers need to order the test. At any of the places, you need to schedule an appointment so that they're not overwhelmed. And that has caused some logistic challenges, because you can imagine when they're doing 500 tests in a day and the schedulers, you have to have adequate schedulers, as well as testers to make sure that to get all the folks in. It's not always the smoothest process. But for adults, you can just schedule it yourself. For kids, I think we need to order it. And I've only ordered it for a couple of my kids so far.
Anyone else?
Sorry.
Oh, go ahead, Jamie.
Just, thinking about me, Heather, and also knowing some of the other people on the call. So I understand that you're saying that it is probably the recommendation, if it's a safe environment, to send kids to school who have CHD. But what about the adults who have CHD in the homes? Like, would it be the same to send my kids to school as it would to send a kid with CHD?
It's I know we've talked about this, Jamie.
Yeah.
And I've talked about it with many of my patients, about sending the adult patients sending kids to school. I don't know. The very lesion specific. Certain lesions, we're, as many of you may or may not know, we're taking part in an international registry in tracking adults with congenital heart disease and how severe illnesses are, so we can get a better sense across the lesions and what the risk factors are. Currently, that registry is in its infancy, and it only has a little over 100 people identified in the registry. Certainly far from enough to make any sense. If someone is relatively young and otherwise healthy, well, we think they're probably at lower risk for severe illness and probably do okay. Can I say that for sure? No, because we do know for those that with more severe illness, they have a higher tendency to clot, to form blood clots. So those that need blood thinners, does this increase their risk if they get COVID? Maybe. We still don't have enough data. Those with single ventricle, are you going to get more severe illness if you're infected because the lungs impact so much on the circulation? We don't know. If you get severe illness with the single ventricle, we think the chances are really high you're not going to do well, but we don't know if you're going to get that severe illness, need to be hospitalized. And what's the risk of your kids, particularly the younger kids, infecting you? It's probably lower the younger they are. But we don't know, and that's why I know some of the families have said, we're not sending our kids, we're doing homeschooling the whole year. Or we're doing remote teaching the whole year. And if that's okay for the family, that's okay. I see some of my kids, I worry to death about their emotional well-being and the risk of suicide. I know there was, in the beginning of last year, there was a suicide in my daughter's orchestra, one of the seniors. and that was devastating. It was the end of last year, the end of the previous year. Sorry, it was devastating. And would in school prevent that, help that? We don't know. There's a lot of unknowns about that. So I think each parent has to understand that the only way to be completely safe is complete social distancing and not allowing the kids to go back. That's not a great answer for our economy. It's not a great answer for the majority of our kids, but it may be for a large number of our families. I'm curious, Tasha, you being a teacher, what have they been discussing at your school? What have you learned? That I'm sure it's a whole different level than what we as the physicians in our ivory towers are experiencing.
She might have stepped away.
Okay.
Oh,
Did she? I don't know. I know that like DPS didn't they do a bunch of trials? I did like some testing because I know of someone who was a teacher in this like testing they did. And pretty much the teachers came back that they didn't feel comfortable. And I think that has to do a lot with why they were pushing it back. That even when they were in like teaching outside with these like pods of 10, the teachers felt very stressed at the end of the day.
And that could be.
Yeah.
I do worry about the teachers quite a bit.
Yeah.
There were some early studies from March and earlier, like in Seattle, where it was hit early, that teachers who were at the head of the class and didn't roam through the class had a very, very small incidence of infection. And there weren't that many kids that were infected, but there was much more interactive groups. The teachers were walking throughout. There was a higher incidence, but these were small numbers.
Yeah.
So it's similar to, you've probably heard about the choir that was in Washington that had choir practice, and one of the members were infected and didn't know it, or was so early they didn't know. And I think about 70% of the choir got infected during that choir practice, and a number of them died. So we have some anecdotal little case series, but we just need more, and we need to try things and really study as we're doing it, what is dangerous, what is not. And it needs to be a very fluid process. I'm a little surprised DPS has put that out till October 16th, but as you said, it could be the teachers. I know the teachers unions had strong say it, where they're getting paid so little compared to teachers around the country, and then exposing themselves as a challenge.
Yeah.
the one thing that, Jamie, we always talk about with Two Hearts is the quality of life. I mean, you want to have a full life, and I feel like that comes into question here with like, do I send my kid to school because I can see he's, my kid's, younger, but I can see that he's impacted mentally by this, not seeing his friends, not being in an organized routine. And so, it's, I don't know. I think that's what makes the decision so hard for most people, is because the quality of life is probably more important than a lot of things, I would think. Right?
Yeah. Well, I agree. And that's why I think, I hope most of our schools do open in a format that gives the kids a chance and the families a chance to make a decision. I think many families are going to opt out because of the risk, but that's okay, and that decreases the risk to the other kids and teachers. Because if 20% of the kids opt out and do it online, but that's the thing. Do school districts like DPS have the technology to do combined in-person remote learning? So audio visual equipment in the classrooms that kids can be remote. I don't know, but I would have to say most don't. And aside from the wealthier school districts, we're exploring that in my church, that we're not going to be reopened until everybody could be at that mass virtually or in person if they decide. So we're installing an audiovisual system so that we can live stream for those that don't feel comfortable or high risk. But at that same venue, we need to put in a new security system because our church was broken into in the midst of the pandemic, and we need to make sure that equipment is secured. So our church isn't reopening until that combined in-person hybrid is set up. But can teachers do that? Or do you need one teacher to do in person and another to do video? That's an operation issue that I'm sure is very challenging for the administrators in the school districts.
I think, is there like, does the hospital have like a month that they're gearing up that they think there's going to be like this more huge spike? Like, I feel like the last time you did the call, you said something about like August or September, them thinking, believing that there's going to be a spike. Is that still the case, or?
Yeah, so the case numbers are tracking very well with what the School of Public Health said, that in July, we're going to start seeing a rise in cases and a spike by end of August or September. And that's exactly what's happening. So the model that the Colorado School of Public Health has predicted is come into fruition. The hospitals are ready. Now it's different. Children's Hospital is going to likely take a different approach than they did now that we have adequate personal protective equipment or PPE for staff and faculty. That Children's is unlikely to close down like we did clinic-wise, although we might, but university might, because University Hospital is going to be caring for a large number of the COVID patients. And we still may have in-clinics in reduced numbers if we have adequate PPE. But that's also something that we're struggling with, that we don't know, and hospitals are hesitant to share that information with the public on how do we have adequate PPE to keep our staff safe. In March and April, we didn't, and we were scared to death that hundreds and hundreds of healthcare providers were going to be infected because they just didn't have adequate ways to protect themselves. And Pam, if you want to comment, your organization probably was struggling as well. That's not as much of an issue, and I don't know if that's because of more imports, domestic rise in production. I don't know.
Yeah, so I'm on the flight team in Northern Colorado, and my husband's a firefighter, and he's a patient of Dr. K's. And actually, there's two firefighters here in Northern Colorado that are patients of Dr. K's, and they've been working closely, as a first responder going into people's homes, and with the precautions that we've been taking at home and they've been taking at work. Like I have a chair outside, I take my flight suit off, my boots, everything stays outside, it doesn't come in. But both my husband and Chris have been much better, right? The peace of mind has gotten better with the increase in PPE. Our challenge was on the flight team is that we had to find fire resistant PPE. We can't use the plastic gowns. We have to use, because then we're just like shrink wrapped if something happens. So we had a challenge, and in Northern Colorado, we cover Logan County, Morgan County, and Weld County, and we had a lot of, most of our cases were coming from multi-generational households and from the meatpacking plants and the processing plants. And that seems to be, and then Morgan and Logan County, they also had huge runs at their nursing homes. So far, we haven't seen very many children. We did have one family that we had a trauma call, and all of them were infected. None of them were symptomatic. They didn't know they were sick. Excuse me. But I know that UC Health has opened up their remote command center, and they expected that they were going to have to be in person, but their demand has been very low. And so our census has also been low in Greeley. So the precautions that people are taking have been working. My friends who are teachers are nervous, but mostly because they just don't know how to prepare. I think once we have a plan, then you can attack it better. The not knowing has been the hardest part. Like Mike with, can I let my son come home to visit his little brother? Like the not knowing is hard. Which we have a heart transplant patient at our gym, and he's been there every single day. And we were all really, really nervous about him. We didn't want him coming to the gym, and he said, I promised this kid I would give his heart a good ride, and I got to give it a good life. And he's been at the gym every day, taking precautions, and he can kick anybody's butt, and he's in his 70s, so he's given his heart a great ride, and he's living a good life and taking all the precautions and doing well.
That's great. Okay. Well, anyone else have anything else they want to add or ask or share? No? Okay.
I'm curious, I know it's a small group. How many on the group have been economically impacted? Either had to take a salary cut or significantly?
I'm on furlough.
So when you say furlough, 10%, 20%?
No,
50%?
fully furlough until I'm in the events business. So I'm not going to know if I'm going to be attached back to my job until probably October, November. It could, I'm only on furlough till the end of the year. And if there's no consensus or direction at that point, then our company could very well go out of business. So.
Sorry to hear that, Mike.
We're fine. Beth is still working, and I've turned into a really great house husband, so it's going okay for now. But I'm not too worried. I'll find something if I need to.
Yeah, the event business has been hit hard.
It's all virtual now, which is fine, but it's a totally different model, and it doesn't accommodate what face-to-face large conferences are designed to do.
Yeah.
The healthcare industry, believe it or not, has been impacted severely. University Hospital, I think, lost $100 million, or UC Health, per month. Children's Hospital hasn't lost as much, but lost quite a bit. But because Medicaid, about 60% of children's hospital clinical revenue comes through Medicaid. And the state has been hit. Medicaid revenue is going to decrease. And so within the School of Medicine, different departments have had furloughs. Most of the departments have mandated furloughs for physicians. Department of Medicine has not, but most of the other ones have, from anywhere from 10 to 25% furlough.
That's significant.
Speaking the events and everything, has there been any has the department's psychiatrist or therapist, has there any been plans or answers to, because Jamie and I, we miss these kids and we connect better when we're with our kids. They are open, they it's a better connection. We feel like we serve them much better when we can see them, and unfortunately we worry about them because they don't always sign on. Some kids don't have the equipment to sign on because they have one computer in their house or whatnot. So has there been anything, have there been any suggestions by the mental health team of how to better serve kids who already depression and all that stuff already hits kids with chronic illness anyway?
There's certainly been discussion, but we haven't seen significant action plans. One of the things in the Heart Institute that one of the double hits is our psychologist, Sarah Kelly, has been out on maternity leave until recently. So we've not been able to interface with her as much to discuss plans. And so there's been an uptick, and there's been plans, but not being one of the mental health professionals, I can't give you a good sense of what's happening, Heather.
Okay, yeah, just because we're always looking, I mean, we need suggestions of how we can impact these kids' lives without being with them. It's really hard. You know, and we get attached, you know, so we want to make sure everyone's doing okay. Anyone else? No? Well, thank you, Dr. K, so much for doing this. We appreciate it so much. You're always so generous with us, and I appreciate you giving us your time. And stay safe and healthy.
That's
Yes,
good to
thank
see
you,
you all
Dr. K.
virtually.
Yes, thank you so much.
Thank you.
And everyone else, stay healthy, stay safe and healthy.
Yep, you too.
Thank you.
Thank you.
Bye.
Bye-bye.